Hello, I'm Dr. Gerald Winehouse, and we'll be talking about the ABCDEF G bundle uh, over the course of the next 30 minutes. I have no financial disclosures, but I should say that I was a member of the committee that put together the guidelines that we'll be discussing. I think that is actually not a conflict of interest, but rather it allows me to speak to the veracity of the process. So these are the guidelines that govern, that really was a way of putting together what is evidence-based management of ICU care that intersects with all these different areas, including pain, agitation and sedation, delirium, immobility, and sleep disruption, which is new to these guidelines. And so each of these 5 elements is connected to outcomes. That's what makes them so important, but they're also so interconnected that it really was necessary to discuss them as a group. So the pain, agitation, delirium, immobility, and sleep guidelines are really what is considered an evidence-based approach to improving outcomes in the ICU. And it was a very rigorous process going through the literature over the course of many years. And they came up with many recommendations, which you see here, or partially represented here. The problem is that this is a bit overwhelming, and many institutions found it somewhat difficult to implement on a large scale. And that brings us to the ABCDEF bundle, which is really the implementation tool that has been advocated for putting all these elements together in a much more user-friendly bedside approach to management. And again, because all 5 of these elements, and really 6 now with sleep, are connected with outcomes, this is really important and very broadly applicable to ICU patients. So the letters stand for A for assessment, prevention, and management of pain. B is for both pairing both and spontaneous awakening trial and spontaneous breathing trial. We'll talk about that briefly. C is for choice of analgesia and sedation. D is for delirium, the assessment and prevention and management. E is for early mobilization and exercise. F is important. It's for family engagement and empowerment. And there is no G yet, but it has been proposed as a way to include and incorporate into this bundle for good sleep. So let's begin with and go through each one of them individually, and then we'll sort of bring it all together at the end and just how much of an impact it can have. So pain, as you know, is a complex function that's influenced by psychological and demographic variables. Subjective pain is experienced differently by different people of different ages and with different comorbidities. And we do know that severe pain is associated with bad ICU outcomes. We also know that if you implement an assessment-driven standardized pain management protocol, outcomes can be improved. The gold standard is always self-report. And so a validated pain scale, this is really the one that's most broadly used and certainly one of the older ones and very easy to understand, just the numeric pain score, where patients rate their pain on a scale of 0 with no pain whatsoever to 10, which is their worst possible pain. Now, not every patient can do that pain score. Some patients are intubated. Others are not intubated, but can't necessarily communicate their pain. So we have behavioral pain scales, and this is one such scale that's recommended and validated for use for patients who are intubated. And it goes through 3 domains on a scale of 1 to 4 across the top for patients with facial expression, which goes from a relaxed face with no facial expression of pain and a score of 1 to grimacing, which would give a score of 4. It also scores movement of the limbs. And for patients who are mechanically ventilated, it also includes compliance with mechanical ventilation, where synchrony, for example, means that they're relaxed, they're breathing in synchrony, and inability to control their ventilation or tachypnea or dysynchrony would give them a score of 4. For patients who are not intubated, it also uses facial expression, movement of the limbs again, because movement can tell quite a bit. If they're relaxed, then it suggests no pain, but if they're tense or retracted, then that's just more pain. And in the case of non-intubated patients, we use vocalization. If they have no pain, they're not likely to be vocalizing. But if they're groaning or howling or screaming, that certainly suggests otherwise. We can use proxy reports, that is, bedside nurses or family members. It turns out that family members are actually better than nurses and physicians at assessing their loved one's pain, but it's still only a moderate degree of assessment. So it's still not as good as patient report, of course. And we do like to use physiologic measurements. We use blood pressure, for example, or heart rate, but these are really only adjuncts. We can't rely too heavily on physiologic measurements, but they can be helpful clues. In terms of pharmacologic management, what's recommended is that to this day, opioids are still considered really the mainstay of analgesia in an ICU. I should say that I would expect that in coming years, after all the difficulties we have with the opioid epidemic and with shortages that we've gone through, I would like to think that that will not always be the case. But I think at this time, and certainly according to the literature and the committee, opioids are still the mainstay. However, it is important that multimodal therapy be considered and that adjuncts be used to minimize the amount of opioids that we do use. And adjuncts that are recommended are acetaminophen, low-dose ketamine, neuropathic pain medications such as gabapentin. Not recommended for routine use are things like IV lidocaine and the COX-1 selective NSAIDs, not because they don't have a role, but they shouldn't be routinely used. They aren't supported by the literature, but they may well have a role in individual cases. Let's not forget the importance of non-pharmacologic management because they can be very helpful. And this is especially true for kids, but certainly in adults. What is suggested by the literature as evidence-based are things like massage therapy and stress reducers like music. Hypnosis and cybertherapy, which is virtual reality, or you can think of it as sort of guided imagery. It's not that they're bad, they're not suggested, but it's mainly because they don't have enough support to justify the cost of training many people to do it. So it's not necessarily that they're wrong to use, but it's hard to make a broad recommendation, which would require training and cost when maybe the literature doesn't support doing that sort of investment. But in any case, non-pharmacologic management can be extremely helpful. And then finally, protocol, and almost always if there's a question, is a protocol better than a non-protocol? It's usually the case that protocolizing something is better, and that's certainly true in the case of pain management, where the use of a validated protocol does improve pain scores. It can shorten lengths of stay, lessen mortality, less use of sedatives, and actually increase the use of non-opioid analgesics, which then potentially leads to less problems with opioids down the road. So very important non-pharmacologic management. Moving to agitation and sedation, there has been a debate for many years about whether we should be using light sedation versus deeper sedation. Deeper sedation at one point was justified as more compassionate because it would, being critically ill is not a pleasant experience. But it turns out that the literature is quite clear that lighter sedation is a better way to manage the overwhelming majority of our ICU patients. There were concerns that patients would be more likely to self-extubate, that they might have more post-traumatic stress if they had greater awareness, and none of these things have been borne out. So light sedation is a much more appropriate management strategy for sedation in the ICU for the overwhelming majority of patients, but there are exceptions. The exceptions being people who either are so difficult to mechanically ventilate that they absolutely just need to be deeply sedated to be synchronous with mechanical ventilation. Patients sometimes in status epilepticus or head traumas. But again, the principle here is that light sedation is usually the correct answer and leads to shorter times of extubation. Lighter sedation means we can extubate patients faster because they won't be under the sedation quite as long, and fewer tracheostomies likely as a result. We've known for quite some time that if you have somebody on a sedative infusion, that it's best to interrupt that sedation and allow people to wake up at least once a day. And that proved to improve outcomes, and that study now is probably 20 years old. Since then, we've learned that if you interrupt that sedative infusion and then pair it or combine it with a spontaneous breathing trial where the ventilator support is really minimized to see if patients are well enough to be extubated, if you do those things together, then your outcomes are even further enhanced. And that really has become the standard of care for the past 10 years now. One question is whether it's necessary to stop a sedative infusion if your patient is already at the sedation level you hope for. So if you have a protocol that's, say, nurse-driven, for example, and the patients are on that sedative infusion, comfortable but awake, interactive, cognitively intact, is there any need to interrupt that sedation? And the answer is probably no. Best of all is if we don't need to use sedative infusions at all. But in terms of sedative infusions, because there certainly will be patients who do need them, we really only have a few choices of which ones to do. And there's benzodiazepines, which 20 years ago was the standard of care, but has largely fallen out of favor now as being too closely associated with the development of delirium and other bad outcomes. So primarily what we prefer now is to use of propofol, which is also a GABA agonist, or dexmedetomidine, which is an alpha-2 agonist. And really those two, at least in terms of the effects of sedation and the ability to wean off them and the side effects, they're pretty equivalent, so that the committee really allows for them to be used interchangeably. Monitoring is important for patients who are not lightly sedated. If we do have to go to deep sedation or use neuromuscular blockade for people who are really in very sick with respiratory failure or for whatever reason, they do need to be on sedation, and they need to be on deep sedation because we can't have a paralyzed patient, for example, who is not sedated, has any awareness. And to do that, we have to monitor them with bispectral index. In terms of sedation, the committee also looked at things like restraints, and that really has to be just a case-by-case discussion of risk versus benefit. Moving to delirium. Delirium, as I'm sure you know, is a syndrome. It's not a disease. It's characterized by an acute waxing and waning change in someone's mental status that's not accounted for by pre-existing conditions, dementia or depression, for example. And it's characterized by inattention and disorganized thinking. We are laser focused these days on modifiable risk factors, because we do know that if somebody develops delirium, it has a pretty close connection with bad outcomes, short and long term. So we know that there are non-modifiable risk factors such as age, pre-existing dementia, coma, and high Apache scores, comorbidities, but we really don't have control over that. So what we're mostly focused on are the ones we do have control over. So benzodiazepine use and blood transfusions, we absolutely do try to minimize as one of the higher risk deliriogenic variables. But there are many others. Other medications, for example, with anticholinergic effects are also very important, and we try to minimize them to the extent possible as a way to prevent somebody from becoming delirious. Monitoring for delirium involves the use of validated scales. I'm showing just two of them here, and it's not because I have any preference or I'm recommending any. These are two of the more commonly used ones. On the left side of the screen is taken from the confusion assessment method for the ICU, where it simply takes those elements of acute onset of mental status change with a fluctuating course and inattention. And in order to be delirious, you have to have those two features. And in the CAM ICU, you also have to have either disorganized thinking or an altered level of consciousness. And then there's the intensive care delirium screening checklist, which is also very popular and very validated and also equally good to use. And there are others. I simply wanted to make the point that any validated delirium tool is better than not using one at all. These are just some of the common ones. We know that delirium, as in terms of its outcomes, is associated with cognitive impairments at 3 and 12 months after discharge. We also know that it's associated with longer hospital stays and higher mortality in hospital and at 6 months. It hasn't been consistently associated with post-traumatic stress, ICU lengths of stay, depression, functional dependence, mortality, or discharge disposition to places other than home. But I did have to say that it is associated with something we now call post-ICU syndrome, which is um, the uh, the fact that many patients who survive their ICU stay and go home are left with problems that they didn't come to the hospital with. And those can include things like depression, post-traumatic stress, and a variety of other physical and psychological problems. Delirium has been connected with that, with longer term issues with these psychosocial issues. So delirium really does have outcomes that are very concerning. And that brings us to how we prevent and treat it. Well, there is no pharmacologic treatment or prevention that's recommended. What has been studied are, for prevention, are haloperidol and atypical antipsychotics, dexmedetomidine, statins, and ketamine. And although some studies have shown some signal and ability to prevent it, the overall sense from the committee has been that the evidence doesn't support its routine use. In terms of treatment, I would say the same thing. There really is no pharmacologic treatment that has met the standards where we were able to make that recommendation that it be used routinely. But clearly, some patients will need to be treated simply because their behavioral manifestations are such that they either pose a risk to themselves or to others. And for those patients, it's sort of case by case. Many people will use haloperidol simply because it's parenteral and it has a quick onset of action. But there is no broad recommendation for any of these drugs. What is recommended and what has proven to be beneficial is prevention with a multi-component non-pharmacologic intervention that focuses on risk reduction. And again, this brings us back to the idea of prevention, which is really our best tool here. Improving sleep, which we'll come to in a bit, improving wakefulness, where we give patients activities, we minimize their sedation, we try to reduce their immobility, which we also will talk about momentarily, where we get people out of bed on their feet, give them things to do, hopefully make them more tired so they sleep better at night. We reduce their visual impairments by giving them their eyeglasses back, or hearing impairments with hearing aids. We reorient them. We try to have their families with them to help sort of ground them in their own reality. And all of these things together have been proven many times to prevent delirium. Immobility was something that was highlighted in the 2013 Pain Agitation Delirium Guidelines as beneficial and part of a delirium management strategy. It's really a set of interventions that optimize people's physical functioning, but it has certainly psychological benefits. And rehab or mobilization is recommended very broadly now for critically ill patients. It's really become part of a standard of care. But there have been concerns raised for getting people active who are quite debilitated in bed, on pressors, on mechanical ventilators, on ECMO, and other mechanical circulatory support devices. So the committee really reviewed an extensive list of parameters that enable us, or which is safe in order to go forward with rehab. And so I thought, because I think this is really well done, I would review that just briefly, that it is okay to do physical rehabilitation for patients who have blood pressures as low as 60 or as high as 130. They can be mechanically ventilated. Their blood pressures can be anywhere from systolics of 90 to 180 and diastolics of 60 to 100. Bear in mind, these are guidelines, but their respiratory rates can be anywhere between 5 and 40 O2 sats as long as they're greater than or equal to 88. It doesn't mean that they can get up and walk around, even in bed, stretching or cycle ergometry. Those things are just as important to be able to do and can be done safely for these patients. And again, just to finish, mechanical ventilation is not a barrier to doing these things, provided they're not profoundly hypoxic or on very high levels of PEEP. It can be done in or out of bed. We have to make sure that the airway is secured, and other catheters as well. This is a patient on ECMO who is getting up and about to walk. You can see that his cannulas are secured. There's somebody dedicated to making sure it stays that way. And it's important, perhaps as important as almost anything we do for patients in the ICU, to keep them active, their muscles working, their circulation going. It's feasible and acceptable to the stakeholders. It's probably cost effective, and it's very highly valued. This is one of those things that probably is very patient-centered. I think this is one of those, if you ask patients, is it important for them to be able to move and get out of bed? I think they certainly would say yes to that. And really, there have been no serious safety events or harms that have occurred when this is done properly. It's labor intensive, but it's incredibly important. And that brings us to sleep. Why is sleep part of the new pain agitation guidelines? And the answer is that it is a potentially modifiable risk factor for patients' recovery from critical illness. And it's unclear whether it is itself the outcome, that is, poor sleep causes poor outcomes, or that it's simply a collateral damage or a secondary effect of a brain that's under stress from critical illness. But it's still very important. We know for certain that the one outcome that all patients will tell you is that it was unpleasant, that sleeping in an ICU was difficult. It was, they slept poorly. They were up a lot at night. They'd stare at the ceilings. In numerous studies over the course of several decades, many different types of ICUs, all continents, patients report it as a problem while they were in the ICU for many, many different reasons. So at least in terms of their ICU quality of life, we know that poor sleep is an issue. Delirium was a little tougher to connect. It certainly seems related. This was a systematic review we did several years ago that looked at 8 studies to date that had specifically targeted improvement in sleep as their endpoint. So these were studies that used either things like eye masks to block out light or ear plugs to block out noise. And some of them were quite complicated tiered processes for helping people sleep, and not doing patient care interruptions in the middle of the night and such. And there certainly was a signal towards showing that there were less cases of delirium when you targeted an improvement in sleep. So it's an unproven connection, but it certainly is probably supported by the literature, and many experts in the field are quite comfortable saying that there is likely a relationship. In terms of monitoring sleep, well, that's very difficult to do in the ICU. The gold standard still remains physiologic or polysomnographic study, which is very cumbersome and difficult to do in an ICU, and really not cost effective, not practical. It's very labor intensive, so it's impossible to recommend that on a broad scale. Very few places can actually do that. But we do think it's important to ask patients or bedside caregivers, clinicians like the nurses, or family members how the patient slept. We think it's important to validate their concerns. We can learn valuable information. There are valid scales like the Richards-Campbell Sleep Questionnaire that may be helpful for patients who can respond. So just because we aren't able to do physiologic testing doesn't mean it isn't important to ask. In terms of trying to facilitate sleep, that's a bigger challenge. There are non-pharmacologic interventions that are tried. There has been some literature on how to manage mechanical ventilation in such a way that sleep is facilitated. And there is a slight signal to suggest that for some patients, assist-controlled ventilation might be better than pressure support, or other volume-related ventilation might be better than pressure support. But I think that the general principle is that synchrony and comfort with mechanical ventilation is probably more important than actually which mode. I can't necessarily prove it, but I think that's really what's most reasonable to conclude. What about other non-pharmacologic therapies like aromatherapy, acupressure, and music? And these have all been tried for ICU patients. And the answer is the literature really doesn't support it. Now, there are clearly going to be patients who will tell you that music helps them sleep. And I think on a case-by-case basis, that has to be considered appropriate. It's probably best to know how people sleep at home in order to know how to help them while they're sick. And certainly if somebody has something like that, I think aromatherapy raised some concern for the possibility it could cause bronchospasm or some irritation. But they could not be broadly recommended. But certainly noise and light reduction is common sense. It has shown itself to help and has really worked its way into the standard of care. It should be standard of care in the ICU, where the lights are turned down, noise is minimized. We're not very good at that in the ICU, but it is very important. In terms of medications to help for sleep, this is always brought up on rounds, and unfortunately, there really isn't a robust literature to really guide this. Melatonin has certainly become a popular drug to use because it's cheap and it has relatively few side effects. The downsides to melatonin is that it's not FDA regulated, so it's quite variable in the quality of drug, and it's not a very potent hypnotic either. The committee wasn't really able to recommend either for or against it based on what's available in the literature. Propofol, however, has a lot of adverse effects, and so to use it solely as a sleep aid is not recommended. The side effects are too great, and it really hasn't shown to improve sleep. It actually can, polysomnography done while people are under the influence of propofol, for example, show very little REM and deep non-REM sleep. So really, there's no reason to use propofol solely as a sleep aid, but of course it's a sedative, and if it's used for that purpose, that's a different story. Dexmedetomidine is a little bit more interesting in that it has some features that make it appealing as a sleep drug, but also still has some of the negative hemodynamic effects. And although there is some literature in support of using it for sleep, it's currently not recommended solely for that purpose, but certainly can still be used as it is otherwise as a sedative. What about other drugs? Benzodiazepines and the hypnotics that are benzoreceptor agonists. These are not well studied. They are associated sometimes with delirium. They have negative effects on sleep architecture and really not recommended. We use antidepressants, or at least I know some of my colleagues do, but there's really no data to support that as a hypnotic in the ICU. Similarly, antipsychotics are used without much data to support them in a critically ill patient. And antihistamines generally are poor sleep drugs. They can be very much associated with the development of delirium in ICU patients and really should not be used at all for this purpose. Coming back to how we do sleep, the best way to do it is by a protocol that combines some of these different non-pharmacologic strategies like noise reduction, light reduction, and when that has been performed, it does help facilitate sleep, and it actually reduces delirium. So that's really the recommendation. So now coming back to our original ABCDEF bundle, remember that it's really just a tool to manage pain, agitation, delirium, immobility, and of course sleep, which is the new kid on the block. And when we did that, or when we do that, I should say, this has now been tested. Does this actually work when you use this bundle together? This was done in 15,000 patients, published just last year in the Society for Critical Care Medicine's journal. And this is what it shows. Interestingly, if you are adherent or compliant with the elements of the ABCDEF bundle, you reduce days in mechanical ventilation, coma, delirium, and physical restraints. Interestingly, significant pain was not really significantly affected by this. But the other interesting thing was that there was somewhat of a dose response curve on this. So if you look at mechanical ventilation as one of the outcomes, with each increased element, which you can see along the x-axis, 20% would be compliant with one of the elements of the bundle, 40%, two elements of the bundle. With each increasing compliant use of the elements of the bundle, the effect size was increased, a sort of dose response curve. And that held true for coma, for delirium, and physical restraints. Again, the more compliant with each element of the bundle, the less likely you were to have these bad outcomes. So it really does validate the importance of using all elements of the bundle. So just a few take-home points. Pain is assessed with validated tools, managed with opioids as needed, but non-pharmacologic and non-opioid adjuncts are extremely important, and protocols do help with that. Agitation, once again, light sedation is better than deep sedation, except for specific circumstances. If you do have to use a sedative infusion, then either a daily interruption to allow for people to begin to wake up and metabolize those metabolites, or nurse-driven targeted protocols are advised. For delirium, we assess it regularly. Pharmacologic prevention and treatment is not recommended. It's really prevention and modifying the risk factors that is most effective. For immobility, rehab and mobilization is done safely. It can be done in bed or out, and it is recommended for most patients, even ones you think might be a little marginal in terms of their stability. It's been done, and it's been done safely. And finally, sleep. We know that ICU patients sleep poorly, and this does have consequences. Non-pharmacologic interventions are best. There really is no pharmacologic treatment that has yet proven broadly and can be recommended. In terms of just a few questions, which of the following statements is not true? A, opioids are the mainstay of analgesia in the ICU. B, agitated patients often do not need more sedation. C, delirium is a syndrome, it's not a disease. D, mechanical life support devices are not a contraindication to mobilization for many patients. And E, patients who sleep poorly in the ICU should be given hypnotics. Well, the correct answer that is not true is E. Opioids are the mainstay of analgesia in the ICU. Agitated patients often do not need more sedation. They may need an adjustment in their mechanical ventilation or something else to help them, but sedating is probably the wrong instinct and maybe a last resort. Delirium is a syndrome, that's correct. It is not a disease. Mechanical life support is not a contraindication to mobilization. I just showed you a picture of somebody on ECMO. That's considered a mechanical support device, and you can walk people on ECMO. But patients who sleep poorly in the ICU really should be given as much non-pharmacologic help as possible. Try to keep them awake and active during the day. Try to keep a quiet, safe, and comfortable environment for them at night to sleep. And then really hypnotics would be pretty much a last resort, although I acknowledge that sometimes we get to that point. And question number 2, which of the following statements is not true? A protocol for pain management is recommended. B, a validated assessment for delirium is recommended as routine practice. C, there's no validated sleep assessment recommended for routine use. D, sleep is best managed with a multi-component protocol primarily involving non-pharmacologic interventions. And E, walking patients on a norepinephrine infusion is contraindicated. And the statement that is not true is E, that walking patients on norepinephrine is contraindicated. We still can do it. Generally, we don't do it if patients are on escalating or high doses of norepinephrine, because that would suggest that they're pretty hemodynamically unstable, but a low dose of epinephrine or norepinephrine would be fine. A protocol for pain management certainly is recommended. Protocols in general probably are recommended as a way of managing patients and trying not to forget certain things. A validated assessment for delirium is recommended as routine practice, and that certainly is true. There is no validated sleep assessment recommended for routine use, and that is true, but it is certainly recommended that we ask patients about how they're sleeping. And there are sleep assessments that are under development now. And sleep is best managed with a multi-component protocol, primarily involving non-pharmacologic interventions is true. It's also, just parenthetically, good to know how patients sleep before they're in the ICU, because that can sometimes give you clues to how you can help them sleep while they're sick and in the ICU. And so that concludes my talk. Thank you very much.